Most people believe that if a medication has been prescribed by a doctor, or if it can be purchased at any pharmacy without a prescription, then it must be safe. The physician knows best. The label is reassuring. The bottle has been through review. Just take it as directed. I used to accept that framework without much question, until I started noticing a pattern that kept appearing in cardiology practice. Older adults arriving with new symptoms. Elevated blood pressure that had been stable for years. New episodes of irregular heart rhythm. Unexplained fluid retention. Fatigue that seemed to come from nowhere. And in case after case, the common thread was not a new disease. The common thread was a new medication, or a combination of medications, that had quietly begun affecting the cardiovascular system. Here is what almost no one explains when a prescription is handed over. The aging heart is more sensitive to certain classes of medication than the younger heart was. Dosing, interactions, and duration of use all matter more with each passing decade. And several commonly used medications, both prescription and over-the-counter, deserve particular attention once a person is past 60. Today, I am going to walk you through 5 categories of medication that deserve careful conversation with your doctor if you are taking them regularly after the age of 60. This is not a video telling anyone to stop any medication on their own. That would be dangerous advice, and it is the opposite of what I am suggesting. The message is that these categories of medication have known effects on the heart that are worth understanding, worth monitoring, and worth discussing at your next appointment. Informed patients partner with their doctors better. Better partnerships lead to better decisions, and better decisions over years lead to better cardiovascular outcomes. Let me begin with a concept that explains almost everything about medication safety in older adults. The aging body handles medications differently than the younger body. The kidneys clear many drugs more slowly. The liver processes certain medications less efficiently. The balance of body water and body fat shifts, which changes how drugs distribute through the body. And the cardiovascular system itself is more sensitive to changes in blood pressure, heart rate, and fluid balance. All of this means that a dose that was perfectly appropriate at age 50 may be too much at age 75. A combination that caused no problems at 60 may produce meaningful effects at 80. This is not about whether medications are safe in general. It is about whether the specific dose, the specific combination, and the specific duration are appropriate for the specific person at the specific stage of life. That conversation is often missing, and it deserves to be present at every medication review. The first category worth careful attention is non-steroidal anti-inflammatory drugs, commonly known as NSAIDs. This category includes widely available over-the-counter medications such as Ibuprofen and Naproxen, as well as prescription-strength versions of the same class. These medications are genuinely useful for pain, inflammation, and certain conditions. They are also among the most commonly used medications in older adults, often purchased without a prescription, often taken daily for knee pain, back pain, headaches, or general aches. Here is what the label does not emphasize. Regular use of NSAIDs has been associated with elevated blood pressure, fluid retention, reduced kidney function, and, with prolonged use, increased risk of heart attack and stroke. These effects are dose-related and duration-related. An occasional dose for an occasional headache is generally not the concern. The concern is daily or near-daily use, often self-directed, often at doses that would prompt a careful conversation if a prescriber were involved. The practical implications are significant. In older adults, NSAIDs can reduce the effectiveness of blood pressure medications, meaning that a previously well-controlled blood pressure may creep upward without any obvious reason. They can trigger fluid retention, which in someone with underlying heart disease can precipitate heart failure symptoms. They can reduce kidney function, which in turn affects how other medications are processed. and they can increase the risk of stomach bleeding, particularly in combination with common blood thinners. If you are over 60 and you take an NSAID more than occasionally, that pattern deserves explicit discussion with your doctor. Alternatives often exist. Acetaminophen, which works differently and generally has less cardiovascular impact, is often a safer choice for routine pain. Topical pain relievers, applied to the skin over the affected area, deliver medication more locally with far less systemic effect. Physical therapy, heat, ice, and targeted exercise can address many causes of chronic pain without any medication at all. None of these options are inherently better for every patient, but all of them are worth discussing. The second category involves certain medications used to help with sleep or anxiety, particularly in the class called benzodiazepines and related sleep medications. These include several commonly prescribed drugs that act on the same brain receptors. For short-term use in specific situations, these medications have a role, but in older adults, particularly when taken regularly over long periods, they are associated with several concerns that affect overall cardiovascular and physical health. The risk of falls is substantially increased, and a fall in an older adult can produce a hip fracture, a head injury, and a cascade of complications that profoundly affect heart health over time. The risk of cognitive impairment is also recognized, with effects on memory and alertness that can be more pronounced in older users. And there is a specific concern about disrupted breathing during sleep, which in someone with underlying sleep apnea can worsen the cardiovascular strain we discussed in another video in this series. The important point is not that anyone should abruptly stop a sleep or anxiety medication. Abrupt discontinuation of certain medications in this class can cause serious withdrawal symptoms and should never be attempted without medical guidance. The point is that if you have been taking one of these medications regularly for months or years, a thoughtful conversation with your doctor about whether the dose could be reduced or whether the medication could be gradually tapered under supervision is often worthwhile. Alternative approaches to sleep and anxiety, including behavioral strategies, sleep hygiene changes, and in some cases other medication classes with different safety profiles, exist and are often underused. The third category involves a specific group of medications often used for bladder symptoms, allergies, and certain sleep aids that contain compounds with what pharmacologists call anticholinergic properties. This is a class of medications that includes some very common over-the-counter products. Many older adults take one or more of these without realizing that they share a common mechanism. The cumulative effect of multiple anticholinergic medications is sometimes called anticholinergic burden, and it has been associated in research with cognitive decline, falls, urinary retention, and in some cases, worsening of certain cardiac conditions. Specifically, these medications can increase heart rate and, in susceptible individuals, can contribute to rhythm disturbances. The practical advice is to review every medication, prescription and over-the-counter, with a pharmacist or physician at least once a year, and to ask specifically whether any of them fall into this category. Many older adults are surprised to learn that a common sleep aid they have been using for years, a common allergy medication, and a bladder medication all share the same underlying mechanism and together exert a meaningful effect. The fourth category involves certain decongestants and cold medications. These are particularly common because they are widely available without a prescription, often in combination products marketed for cold and flu symptoms. Many of these products contain pseudoephedrine, phenylephrine, or related compounds that narrow blood vessels to reduce nasal congestion. The same action that reduces nasal congestion, however, also raises blood pressure and increases heart rate. In younger adults with healthy cardiovascular systems, the effect is usually mild and transient. In older adults, particularly those with existing high blood pressure, heart disease, or rhythm issues, the same dose can cause a more pronounced and potentially concerning effect. Blood pressure can rise significantly. Heart rate can become rapid. In some cases, underlying rhythm problems can be triggered. The practical advice is to check the active ingredients of any cold medication before taking it, particularly for anyone with a history of heart disease, high blood pressure, or rhythm abnormalities. Nasal saline sprays, steam inhalation, hydration, rest, and targeted treatments for specific symptoms often provide relief without the systemic cardiovascular effects. For persistent cold symptoms that interfere with daily life, a conversation with a doctor about appropriate options is generally safer than self-treatment with combination products whose ingredients may not be well understood. The fifth category involves certain corticosteroids, particularly when used for extended periods. Corticosteroids include several widely prescribed medications used for inflammatory conditions, respiratory issues, certain autoimmune conditions, and a variety of other indications. Short courses of steroids for specific conditions are often necessary and appropriate. Longer-term use, however, has well-recognized effects on the cardiovascular system, including elevated blood pressure, fluid retention, changes in glucose metabolism that can worsen or trigger diabetes, and with prolonged high-dose use, changes in cholesterol and body composition. In older adults, these effects are often more pronounced and harder to reverse. This is not a reason to avoid steroids when they are genuinely needed. It is a reason to ensure that any long-term steroid prescription is periodically reviewed. Is the underlying condition still active? Is the current dose still the lowest effective dose? Are there steroid-sparing alternatives that could be introduced? These questions are appropriate to raise at any medication review, and they are exactly the questions that thoughtful prescribers welcome. Now let me discuss a broader issue that affects all 5 categories, and in fact, nearly every aspect of medication use in older adults. Polypharmacy. This is the clinical term for taking multiple medications simultaneously, often prescribed by different specialists for different conditions. It is extraordinarily common. Many older adults take 5, 7, 10, or more medications daily, sometimes from 3 or 4 different prescribers. Each individual medication may be reasonable, but the cumulative effect, the interactions between medications, and the ways in which different medications influence each other can be difficult for any single prescriber to track. Research consistently shows that medication-related problems are a major cause of hospitalization in older adults, and that many of these problems could be prevented with periodic, comprehensive review. The recommendation is simple in concept and powerful in practice. At least once a year, bring every single medication, every prescription bottle, every over-the-counter product, every vitamin, and every supplement to a single appointment with either your primary care doctor or a pharmacist trained in medication management. Ask for a full review. Ask whether any medications might no longer be needed. Ask whether any combinations carry risk. Ask whether any doses might be reduced. This one appointment, done annually, can meaningfully reduce the risk of medication-related cardiovascular events. Let me share a story that illustrates why this matters. A gentleman in his mid-70s came to cardiology after developing new-onset atrial fibrillation, an irregular heart rhythm. He also noticed worsening shortness of breath with exertion and increased swelling in his ankles. He had been relatively stable for several years on a combination of medications for blood pressure and cholesterol. When we went through his current medication list in detail, several things became clear. He had started taking an over-the-counter Ibuprofen product daily for knee pain several months earlier, without mentioning it to any of his doctors. His primary care physician had recently added a steroid taper for a respiratory issue, which had been extended because the initial course did not fully resolve the symptoms. An allergist had prescribed an antihistamine with anticholinergic properties, and over the past several weeks, he had been taking a combination cold medication containing pseudoephedrine for what he thought was a persistent sinus issue. None of these additions were unreasonable in isolation, but together they had significantly altered his cardiovascular picture. After a careful review, the ibuprofen was replaced with a topical alternative. The steroid was tapered appropriately. The antihistamine was switched to a newer version without the anticholinergic burden, and the cold medication was discontinued. Over the following 2 months, his blood pressure normalized, his ankle swelling resolved, and his atrial fibrillation became easier to manage. The underlying lesson was simple. No single medication had caused the problem. The combination had. His story is far more common than most patients realize. The pattern of drift, where medications are added one at a time for reasonable reasons, but the cumulative picture is never reassessed, plays out in countless older adults. The solution is not to fear medications. The solution is to ensure that medications are reviewed as a whole, not as isolated prescriptions. There is one additional concept worth introducing: deprescribing. This term refers to the deliberate, supervised reduction or discontinuation of medications that may no longer be needed or whose risks may now outweigh their benefits. Deprescribing has become a recognized part of good geriatric care. It is not about taking medications away from patients who need them. It is about periodically asking whether each medication is still providing the benefit it was originally intended to provide, and whether the risk profile has shifted with age and changing health. A good deprescribing conversation might result in reducing a dose, stopping a medication that was added years ago for a condition that has since resolved, or replacing one medication with another that has a better safety profile. This conversation is entirely appropriate to initiate with your own doctor, particularly at annual reviews or when any significant health change occurs. Let me offer 4 practical questions worth asking your doctor about any medication you are taking regularly. These questions apply to every medication category discussed today and to many others. The first question: what is this medication doing for me specifically, and how would we know if it were working or not working? A medication that cannot be clearly linked to a specific benefit or whose effects cannot be measured in any meaningful way deserves scrutiny. The second question: what are the known side effects that are particularly relevant at my age, and which should I be watching for? A thoughtful answer goes beyond the generic list and addresses the specific risks that matter most for the specific patient. The third question: is this the lowest effective dose, and has the dose been reviewed recently? Many older adults remain on doses that were appropriate years ago, but that could safely be reduced. The fourth question: are there any newer alternatives or any non-medication approaches that might achieve similar benefit with less risk? Medical knowledge changes. Options that did not exist 5 years ago may now be available. A doctor who welcomes these questions is a doctor who is genuinely invested in good care. One more practical point worth highlighting. When visiting any new doctor, any new specialist, any urgent care clinic, or any emergency department, always bring an updated list of every medication, every supplement, and every over-the-counter product taken regularly. Not from memory, a written list, current as of that day, with doses and frequencies. This single habit prevents an enormous number of preventable errors, interactions, and missed opportunities for optimal care. Many pharmacies will print a current list on request. Keeping a copy in a wallet or phone is a simple habit with meaningful benefit. Let me close with a broader point that I hope will stay with you. Medications are remarkable tools. They prevent strokes, manage heart disease, treat diabetes, reduce cholesterol, control infections, and improve quality of life in ways that simply were not possible a generation ago. The goal is not to fear them. The goal is to use them wisely, which means using the right medications, at the right doses, for the right duration, with periodic review to ensure that each continues to earn its place on the list. For older adults in particular, a thoughtful approach to medication management is not a peripheral part of cardiovascular care. It is central to it. Everything shared today is general medical information drawn from published geriatric and cardiovascular literature and from recognized patterns in clinical care. Every individual's medical situation is unique, and every medication decision should be made in partnership with your own doctor, who knows your history, your complete medication list, and the specific context that no general discussion can fully capture. Never stop, change, or adjust any medication on your own without medical guidance. What to do with the information in this video is simple. Bring it to your next appointment. Raise the questions. Ask for a comprehensive review, and then make decisions together with your physician, informed and unhurried. That partnership is exactly where good cardiovascular care in later life is built. Take care of yourself. Stay engaged in your own health, and give your heart the thoughtful medication management it genuinely deserves.